to all of you, Chairman Sir. First of all, I must thank the NCD Committee of the Sri Lanka College of Internal Medicine to giving me this opportunity. It's a wonderful event and very important event in our country. We'll see how important it is as the day go by. During my talk, there will be a brief introduction of what we are going to do, and then it will be mainly discussed under two headings. Firstly, I will discuss about the methods used for cardiovascular risk assessment. And my second part will be some measures for primordial and primary prevention of cardiovascular events after identifying the risk. Atherosclerotic cardiovascular disease is the leading cause of death worldwide. If you look at the WHO bulletin, between 25% to 40% deaths are due to cardiovascular diseases in all the countries, including in Sri Lanka. However, we being South Asians, like Indians, Pakistanis, Bangladeshis, and Sri Lanka, have a especially high risk of developing cardiovascular outcomes. Now, in this chart, you can see what percentage of people or population is in these four countries. In India, there is about 17, almost 18%. And Pakistan and Bangladesh, 2.5% each. And in Sri Lanka, we have 0.25% of the world population. So almost 23 to 25% of the people. That means every fourth to fifth person that we have in world are from these four countries. The important thing is that their risk of cardiovascular diseases are much higher than other populations. They say a person in South Asia developed their first myocardial infarction 10 years earlier than a Caucasian. So you can see how high the risk is. Therefore, as I said at the beginning, it is especially important to assess the cardiovascular risk in this way, and if identified, manage efficiently and accordingly. Coronary artery disease risk assessment is important because there is a long asymptomatic latent period. You can have atherosclerosis and undetected coronary artery disease for a long period before they develop an outcome. Therefore, early detection of coronary artery disease and prompt management is important for prevention of coronary artery disease. When young people die, like boys and girls die at the age of 14 years, 13 years, and when we do the postmortems, we can see early atherosclerosis occurring in their coronary artery. So that is the age that they start this process. And if they have risk factors, the process becomes faster. So if you can intervene as early as possible and do the adequate management, that will be very helpful. So firstly, we'll discuss about the methods used for cardiovascular risk assessment. Now, what I'm talking today is how to assess a completely asymptomatic person who has no history of any heart disease, no history of myocardial infarction, no history of chronic stable angina, no history of revascularization, peripheral vascular disease, or stroke. So, all our assessment is based on investigating these people or assessing these people to identify their risk and prevention of this to prevent a future cardiovascular outcome. What are these cardiovascular outcomes? That include outcomes of coronary artery disease, namely chronic stable angina, unstable angina, coronary revascularization, and fatal or near fatal myocardial infarction, heart failure, atrial fibrillation, or fatal and non-fatal strokes. Now, these patients can be represented in this pyramid. Majority of the patients are asymptomatic, but they harbor risk factors. Some of them are traditional risk factors like age, family history, hypertension, dyslipidemia, and diabetes mellitus, and some are non-traditional risk factors, which I am also going to touch briefly. And also, some people can have atherosclerotic disease, but have no symptoms whatsoever. So when we take measures to prevent at this level, they can be either primordial prevention or primary prevention respectively. Now, if you think of assessing their risk for cardiovascular outcomes, one of the commonest methods we use is assessing the global risk score or GRS of their either 5-year or 10-year cardiovascular outcome risk. Here what we try to do is we put many of the risk factors together. They can be either non-modifiable risk factors like the age or the gender, or else modifiable risk factors like smoking status, diabetes, systolic blood pressure, hypertension, whether they are on treatment or not, and the serum cholesterol levels. We put all of these together and develop a predictive model to estimate the risk of cardiovascular outcomes. Right? So it is a quantitative estimate. The cardiovascular risk prediction method or the chart we use is the WHO CVD risk prediction chart of Southeast Asia, published in 2019. This is what is recommended by the health ministry, and in many colleges, these are the ones that has been accepted to use in Sri Lanka, because this is the mostly validated risk prediction chart in Sri Lankan population. So there are two of these charts. So I want all of you to be familiar with these charts. This chart on the screen is a lab-based chart. There you include there are two columns. You can see two parts. One is for the diabetic patients and the other one for the non-diabetic patients. But you also include their age, their blood pressure, and many of the parameters. And then you try to assess the risk. So you can assess the risk less than 5% risk of having a cardiovascular outcome in 10 years, 5 to 10%, 10 to 20%, 20 to 30%, and more than 30%. So depending on that, either mild risk, borderline intermediate risk, and severe risk you can. So this is one of them. The other chart does not involve any lab investigation. There you use only the age, the BMI, and the blood pressure. That can be used in any place where you don't have even the lab facilities and even on the chart, on the field. So that is also recommended, especially for primary care settings. Other than that, the two commonly used risk prediction charts are this chart of ASCVD. It is a mobile app or a web-based app. You can calculate your risk of 10-year risk of cardiovascular outcomes in the web using this app. This is produced by the American College of Cardiology and the American Heart Association. And also this score called the SCORE, Systematic Coronary Risk Estimation, by the European Society of Cardiology. And they also have another one called SCORE 2 and SCORE OF. I'm not going to go into detail, to specially assess the very high risk individuals. Now, there are several other risk prediction charts, but what we want to concentrate is the WHO CVD risk prediction chart, because that is the recommended one by the Health Ministry and most of our colleges. So using this risk prediction chart, you calculate the risk of the cardiovascular outcomes, and you can categorize the patients into the low risk, intermediate risk, and the high risk. Although that chart shows several categories, we have come to one consensus in Sri Lanka to use it like that to simplify the risk categorization. So if the risk is below 10% of cardiovascular outcomes in 10 years, it is low risk. 10 to less than 20% is intermediate risk, and more than 20% is high risk. So if the patient is low risk, usually what is needed is the lifestyle management. It is unlikely for them to gain a substantial benefit by medicines or revascularization procedures. But intermediate risk patients, they can be further investigated, and they can be given lifestyle modifications, and if necessary, pharmacology therapy. However, high risk patients are the group of patients who are more likely to be benefited by the medicines and the revascularization procedures. So that is how you use the global risk assessment chart. The other important thing to do in the risk assessment is obtaining the family history, which is very easy. It is a simple thing, inexpensive, but a very valuable. As you know, the family history of premature coronary artery disease is associated directly with your risk of coronary artery disease. So what is the family history of premature coronary artery disease? If any of your relatives, first degree relatives, that means your parents, your siblings, or your children, develop a coronary outcome like a myocardial infarction or a revascularization below the age of 55 years for males, below the age of 65 years for females, you are at an increased risk. So this piece of information is very important, which is not taken into consideration in the global risk assessment charts. The other important thing is looking for, again, connected to what I discussed in the previous slide. If there is a premature coronary event or a sudden cardiac death, investigating the children for familial hypercholesterolemia is also very important, and treating accordingly. So remember, these are the three very important measures in the cardiovascular risk assessment. Assessing the global risk score, taking the family history of premature coronary artery disease, and if there are coronary outcomes in the family, investigating the young individuals for familial hypercholesterolemia and treating accordingly. For this, you don't need a lot of money. They are all inexpensive, very straightforward, simple procedures. But these are the ones that have been proven again and again, and has a lot of scientific evidence of benefit in the cardiovascular risk assessment. I am not going into details of level of evidence, but the people who know about the level of evidence in guidelines, these are the class 1 recommendations. But besides that, there are various other things we can do that can be benefited. There are some evidence that they can be benefited if you look for them in the individuals. That is like psychosocial factors. If the patient has like chronic stress or depression or anxiety or some psychiatric disorder, and also low economic status, poor education, high stress in the job, low income. So likewise, all these are connected to increasing cardiovascular risk. And there are female specific conditions. When the females had pregnancy-induced diabetes, so hypertension, preeclampsia, premature menopause, polycystic ovarian disease, they are at increased risk. So I'm not going to do details, but just remember. And chronic kidney disease is also an independent risk factor. The EGFR is reciprocally associated with the cardiovascular risk. And detection of microalbuminuria is independently associated from chronic kidney disease. So people who develop microalbuminuria has an increased cardiovascular risk, irrespective of their EGFR. And high sensitivity C-reactive protein. As you know, atherosclerosis is associated with vascular endothelial inflammation. So this is a measure of vascular endothelial inflammation, and that is associated with coronary artery disease, peripheral vascular disease, and stroke. Then coronary calcium score can be measured if the facilities are available, and that is also can predict the risk. The calcium coronary score is measured using Augustin score. When the Augustin score is more than 300 units, that is again associated. And there are a few things that we don't normally consider. The people who have autoimmune diseases like rheumatoid arthritis, active rheumatoid arthritis, and also other diseases like ankylosing spondylitis, psoriatic arthritis, SLE, they are also at high risk. And people who develop premature erectile dysfunction, because erectile dysfunction also can be associated with atherosclerosis of the penile arteries, and that is associated with peripheral vascular disease and coronary artery disease. And also resting electrocardiogram, resting ECG, if there are ST changes in the resting ECG, if there is LVH in the resting ECG, they can be associated. So there is some evidence that these are benefited, but not as beneficial as the first three I mentioned. But we can look for this in our individuals also. But there are few other things, they may be beneficial. There's no much of evidence. Now, in that level of evidence, we take this as class 2B. There's no much of evidence, but if you want, you can check. Like ankle brachial index is a bedside test. If it is less than 0.9, there's increased risk. You can use carotid ultrasound for a carotid artery plaque assessment. Can do hemoglobin A1C. Can do exercise treadmill test, transthoracic echocardiography, myocardial perfusion imaging, and of course, obstructive sleep apnea. All these are associated with increased cardiac risk, but only less evidence. But there are things that people think that they are of use, but I am only talking about the asymptomatic individuals with no history of coronary artery disease or any heart disease. If you assess them, these are not of any proven benefit. But a lot of people come to do CT coronary angiography to look at their coronary arteries, no proven benefit. Stress echocardiography, MRI for plaque assessment, genotype testing, BNP, lipoprotein associated A2 levels, measurement of arterial stiffness. There are various methods to measure the arterial stiffness, and lipoproteins and apolipoprotein levels measurement. They are of no proven benefit in assessing asymptomatic patients for their coronary artery disease. So this is the summary of cardiovascular risk assessment. You first go for traditional risk factors, whether they have diabetes, hypertension, hypercholesterolemia, and then you can use a global risk assessment using the WHO CVD risk assessment chart. And also you can consider non-traditional risk factors. As I mentioned, there are some which can be benefited, or some which may be benefited if the patient has autoimmune disease or a malignancy or they are psychological disorder, they are also at increased risk. You can consider them as well. And you can then develop an individual or personalized risk profile for that patient and design your management plan. So that is what we need to do in the cardiovascular risk assessment. Remember the first three things I mentioned, using the global risk assessment chart, taking the family history of coronary artery disease and other diseases, and also looking for individuals who can have familial hypercholesterolemia with their history of premature coronary events and identifying them at very early ages. They are the most beneficial things for cardiovascular risk assessment. Then I'll go for my second part of the talk. I briefly discuss with you what are the measures for primordial and primary prevention of cardiovascular events. Of course, much of it is management of diabetes, hypertension, and hyperlipidemia, which I am not going to discuss in detail because it is already planned for today after my talk. Now, dietary measures are very important, and diets that have higher amounts of vegetables, fruits, legumes, nuts, grains, and fish are the recommended diet. We all should know what are the favorable diets and what are the unfavorable foods. So we should eat more of favorable foods and should minimize the unfavorable foods. And replacement of saturated fat in the diet with monosaturated or polyunsaturated fats are very helpful. And dietary salt and cholesterol restriction should be done. And also minimizing the processed meats and refined carbohydrates and sweetened beverages are helpful. Now you can see in the first sentence I have said recommended because that has the most amount of scientific evidence. Other three I have said helpful because there are no much scientific evidence, but we know that they are helpful. But the last two are of no benefit. Using fish oil supplements, a lot of people take fish oil supplements for prevention of cardiovascular outcomes. There's no proven benefit. And also trans fats should be avoided. Right? So physical activity, everyone should do at least 150 minutes of moderately intensive physical activity or 75 minutes of vigorous intensity physical activity a week. That is the recommendation. Right? And gradual increase you can do once you have started doing them, you can increase this to up to 300 minutes of moderate intensity exercises or 150 minutes of vigorous intensity exercise a week. And this is recommended for healthy men and women. Now, if you have some disease condition or if you have not started doing exercises, you can discuss with your doctor and you can settle yourself to a lesser amount of physical activity. Even some amount of physical activity is beneficial. Then another very important aspect of the cardiovascular risk prevention is tobacco cessation. Everyone should be advised. This is 100% abstinence of smoking. Now, tobacco, when we think about tobacco, it can be inhaled like smoking, or you can even chew tobacco. So all are equally bad. Although we don't have much of the medicines that we use for tobacco cessation, if available, we can use varenicline and bupropion. Bupropion is available in Sri Lanka, but that is the most important thing in prevention or abstinence of tobacco is the willpower. And you proper counseling, get the help from the family and friends, and give the willpower and confidence to the patient, you can do it. Then briefly, weight control. We need to measure the BMI in all the individuals and advise them about their ideal weight according to the height. And usually what we recommend is to reduce not more than 0.5 kilograms per week, because otherwise it won't be sustainable. And this is mainly done by lifestyle interventions and counseling But pathologically obese people, there are other methods also in medically and surgically. Diabetes, I am not going to discuss. These are the main steps of diabetic control. I am sure Dr. Suranagamanilgam will go through all this. Dietary control, regular exercises, weight reduction, oral hypoglycemic and insulin, statin therapy for lipid lowering, optimal blood pressure control, and some people might be benefited with low dose aspirin. Hypertension, again, I am not going to go through. Dr. Kumudini Wijesinghe will be doing it. But mainly it is lifestyle modifications like weight reduction, regular exercises, salt restriction, and increased consumption of fruit and vegetable. So those are the main things. And also using appropriate use of antihypertensive therapy. You can use any of the classes of antihypertensive medication. Then hyperlipidemia, again, I'm not going to discuss because Professor Chamila Metanand is going to do it soon after my talk. And it will be mainly dietary control, regular exercises, weight reduction, and statin and other cholesterol lowering medication therapy. Now, another important aspect is behavioral changes. Now, as I said at the previously also, it is associated with psychological conditions, even the personality trait, the stress level, your anxiety level, all are. So cognitive behavioral strategies such as motivational interviewing are important and approached by multidisciplinary healthcare professionals, physicians, nurses, dietitians, because to encourage them to change their lifestyle for favorable lifestyle pattern, and also multimodal interventions to get rid of habits and give them health education, tobacco cessation, teaching them about the healthy diet, regular exercise. All these are important. And management of psychosocial factors also we should look into and advise them accordingly. So psychotherapy, medications, psychotherapy, the medications, multidisciplinary management can be helpful. What about low dose aspirin? Low dose aspirin can be used for primary prevention. There is evidence, but mainly it is used of patients with high risk category at the age of 40 to 70. These are the people who might get benefited. Strong family history of premature coronary artery disease, high coronary artery calcium score, more than 300, diabetes for more than 10 years, microalbuminuria, chronic kidney disease, inability to achieve target lipid, blood pressure, and blood glucose control in spite of all the measures we take. Those patients will be benefited by aspirin therapy for primary prevention. Right? Other important factor is people who have had malignancies. We also tend to ignore this. People who have had chemotherapy and chest radiotherapy are also at increased risk of developing cardiovascular diseases. So prophylactic treatment with beta blockers, ACE inhibitors, and statins may be helpful in prevention of LV dysfunction who have had high doses of cardiotoxic chemotherapy. And also, when these patients come, optimization of their risk conditions like their diabetes and the blood pressure and the cholesterol levels are important, because when they are on chemotherapy, they tend to ignore the management of their other disease conditions, and sometimes they may even stop them. And also because of the anorexia and all these conditions, they might stop. Therefore, we should encourage them to take the medicine properly and optimally control the cardiovascular risk conditions, because they are at very high risk of developing a cardiovascular outcome. So all of my talk was based on these two guidelines, which was published by the NCD unit of the MOH in collaboration with the Ceylon College of Physicians and all its sister colleges, including the Sri Lanka College of Internal Medicine. One was cardiovascular risk management, total cardiovascular risk assessment approach, guidelines for primary health caregivers. And the other one is national guideline for risk assessment and primary prevention of cardiovascular diseases for secondary and tertiary healthcare level. So please find these two guidelines and follow them, and that will give the good information about all what I discussed today. Thank you very much.